Good evening, ladies and gentlemen. Now we have reached the last event of another successful academic program of day one, SIMCOM 2021. This is going to be a virtual presentation. So it's with my great pleasure, let me introduce our speaker. He is Robert McLean. Dr. McLean is currently working as a consultant rheumatologist and medical director of Northeast Medical Group of Yale New Haven Health. He is associated clinical professor of Yale School of Medicine. Dr. McLean was served as a president of American College of Presidents from 2019 to 2020. Dr. Macmillan is going to talk about an internist updated diagnostic approach to vasculitis. Dr. McLean, over to you.
Hello to my internist colleagues from Sri Lanka. I'm Robert McLean. I'm happy to have the opportunity to speak to you today about an internist diagnostic approach to vasculitis. The outline for our 30-minute talk today will be early descriptions in the days of eponyms, the development of classification criteria, an understanding of pathophysiologic mechanisms and how they led to current-day criteria and nomenclature, and practical clinical advice at the end. Over time, vasculitis has had different descriptions, and the first one that was really in the published literature was in 1866, when the term periarteritis nodosa was introduced by Kussmaul and Mayer. Kussmaul is a name you might recognize, as his name was attached to a number of different conditions and physical findings. Anyway, this initial report in 1866 described a patient with fever, anorexia, muscle weakness, paresthesia, myalgia, abdominal pain, and oliguria. The patient was found to have nodular inflammatory lesions in medium-sized and small arteries throughout the body. So this was on an autopsy because the patient did not survive. And they called this condition periarteritis nodosa. That term was the term that was really referred to just about all of the different conditions that seem to involve the vasculature, for almost the next decade. And it was in 1953 in the New England Journal of Medicine that we see one of the first attempts to start to classify what seemed like a number of different conditions that this was actually referring to. And Pearl Zeek, in this really comprehensive piece, talks about the tendency in recent decades to include all lesions of this morphology in the category periarteritis nodosa, but this was causing much confusion. One of the big changes here was they started to use the term necrotizing angiitis, and one of that was reasons for that was because it was recognized that vascular lesions were seen in multiple different areas, not just arteries, as periarteritis nodosa would suggest. So the report here in 1953 included a review of the change in uses of the term and made some suggestions. In that paper, as I say, the large reason was that there was confusion in usage, yet as greater techniques and more pathology was being done, it had become recognized that there were different conditions being described here. So they were trying to decide, is this one clinical syndrome with different findings, or are we seeing different pathologic entities? So Zeek described 5 major categories called necrotizing angiitis, periarteritis nodosa, hypersensitivity angiitis, what was called rheumatic arteritis, so vasculitic problems seen in rheumatoid arthritis, allergic granulomatous angiitis, what we now know or have come to call Churg-Strauss syndrome as well, and temporal arteritis. And we'll go through some of these. So at that point, you had those 5 categories being suggested. Realize that many of the different conditions that we saw were actually called syndromes because the pathophysiology was not understood, and they were really kind of grouped together simply as constellations of symptoms. and they were given the names of the people who sometimes were the first or early ones to describe them, things that we know as Henoch-Schönlein purpura, Churg-Strauss syndrome, Wegener's granulomatosis, Behçet's syndrome, Takayasu arteritis. There are a couple others, but I'm just going to go through these 5. In my experience as a rheumatologist, I always found these names quite interesting, and I wondered at different times, how did their names get attached to these conditions? Henoch-Schönlein purpura was first used as a name for the condition known as that in 1948 when it was described in the Quarterly Journal of Medicine. And this physician, Douglas Gairdner, described a family of conditions with some common features: purpura, acute nephritis, rheumatic fever, and what was called then polyarteritis nodosa in 1948. And based upon some research, felt that there was a common etiology, some sort of antigen-antibody reaction that was occurring in the vascular endothelium. So that was kind of the first time the eponym was used. So who were Henoch and Schönlein? Well, Henoch lived from 1820 to 1910 in Germany. He worked in children's diseases at Berlin Charity Hospital, which was the first children's hospital in Germany, wrote extensively on childhood illness, and was considered a pioneer of German pediatrics. In terms of the specific condition, in 1868, he had seen a 15-year-old who had purpura and abdominal pain, and in 1874, he actually wrote a report on 4 children who had bloody diarrhea, abdominal pain, rash, and painful joints. The condition was not named after him at that point. That was 1874. Who was Schönlein? Well, Johann Lucas Schönlein lived from a bit earlier, from 1793 to 1864, also in Germany, the town of Bamberg. And he was a professor of pathologic anatomy at the University of Würzburg. He was there all of his career. He was a well-known clinician. His clinic became one of the most famous in Germany. In 1840, he actually had left to Switzerland for some political reasons, came back to Prussia to be the chair of clinical medicine in Berlin, and was actually appointed to be the personal physician to King Frederick Wilhelm II, which is quite stunning. In 1837, a document was put together that was compiled by his students on notes from lectures, talking about descriptions of petechiae and associated joint troubles. He was not a big writer, but his students had put this together. So between those two people having written about this in the past, it was not until 1948 that it actually was given the eponym that it now had. The next eponym we'll talk about is Churg-Strauss syndrome. Well, in this case, Churg and Strauss actually worked together, and they published together a paper in the American Journal of Pathology in 1951 called Allergic Granulomatosis, Allergic Angiitis, and Periarteritis Nodosa. It was an autopsy study. Once again, we didn't have treatments. Most of the people who had many of these conditions died. The autopsy study was of 13 cases describing, quote, a syndrome of severe asthma, fever, and hypereosinophilia, accompanied by symptoms of vascular embarrassment in various organ systems. So how did they get around to this? Well, Churg lived from 1910 to 2005, had been born in Poland, trained in pathology in Europe. 1936, for obvious reasons, emigrated to New York City, where his uncle was the chief of the skin clinic at Mount Sinai Hospital. So that's where he got started, and he became a pathologist and worked there for decades, becoming well known in different stains and pathologic techniques. Lotta Strauss, 1913 to 1985, also born in Germany, and she also did medical studies in Europe. In 1938, for similar reasons, moved to New York City. First was working in microbiology and then pathology. She didn't land at Mount Sinai Hospital until 1941, where she specialized in pediatric pathology. So obviously they worked together at Mount Sinai and put together this paper, which subsequently was given their name. Wegener's granulomatosis. So Wegener wrote a paper called On Generalized Septic Vessel Diseases in a German pathology journal in 1936. It was a report on the findings in 3 patients, all of whom were in their 30s, who had very similar clinical courses. described as a septic course with extremely severe necrotizing granulomatous inflammation of the inner nose with involvement of the larynx and pharynx. Renal changes in the form of a toxic localized glomerulonephritis were seen pathologically, generalized arteritis with a picture of periarteritis nodosa. So that was a 1936 description. The eponym attributed to him was actually first used in the titles of two papers describing the condition, but not until 1947, 1948. So who was Wegener? Well, he lived from 1907 to 1990. Born and lived in Germany his whole career, studied and trained at the University of Kiel. Through the late 1920s and 1930s, he had academic appointments there in pathology. What's important about Wegener is that in 1932, research showed later he had joined the Nazi Party. He worked high up as a well-known physician in the Nazi Party. His involvement in medical atrocities was actually never documented, and many people looked for evidence of this. But on the basis of this knowledge and a lot of backlash around other physicians who had been involved in the Nazi Party back in the 1930s, it was roundly agreed to remove his eponym from this condition. Behçet syndrome is the next one. It was first described in 1936 when Behçet, who we'll get to in a minute, presented 3 cases at a meeting of the Society of Skin and Venereal Diseases. It described a couple patients, one with years of recurrent aphthous stomatitis, genital ulcers, erythema nodosum, and visual problems. Another patient had irritation in the eyes, lesions of the mouth and genitals, and the third patient had oral pemphigus-like wounds, eye irritation, and abdominal pains. In 1947, after other cases had been described elsewhere, at an international medical congress in Geneva, a suggestion was made to name this condition Behçet's disease. Now, who was Behçet? He was Turkish, lived from 1889 to 1948, studied in Turkey initially, where he specialized in dermatology and venereal diseases, which went together back in those days. He had academic appointments in Turkey, and in 1933 became a professor and the clinical director of dermatology and venereal diseases at the University of Istanbul, so quite prominent in Turkey. And in 1940, a monograph he wrote was called Clinical and Practical Syphilis, Diagnosis and Related Dermatoses, for which he was very well known, and I think may have had some early descriptions of Behçet syndrome. He died in 1948 at the young age of 59. He was a very heavy smoker. I should note that if you look here, he died only 1 year after the condition was given his name. Takayasu arteritis is the final eponyms we'll talk about. It was first referred to as Takayasu's disease, at least in the English literature, in 1952 in the American Heart Journal, when it was also referred to as the pulseless disease. The syndrome was characterized by the loss of pulsations in the radial arteries and ocular findings, including progressive formation of AV anastomoses, visual disturbances, and syncopal attacks, with chronic circulatory insufficiency, and this in 1952 was the first case to be reported outside of Japan. So when was it actually first described in Japan? Well, in 1905, Takayasu, at an annual meeting of the Ophthalmology Society of Japan, actually presented a case. This case was actually not presented in written abstract format until 1908. So this case report, presented verbally in 1905, was about a 21-year-old woman who, from his ophthalmologic standpoint, had an interesting, quote, coronary anastomosis of central retinal vessels. It's quite interesting that that case report did not have any description of any other symptoms or systemic vascular symptoms. So it was not until later that people pulled these together that his name was attached to it. So as you can understand from my comment, Takayasu was actually an ophthalmologist. He did medical training in Germany after being born in Japan, went back to and did training in Germany as many did in the 1880s and 90s. He lived from 1859 to 1938. In 1901 was made a professor of ophthalmology at a fairly prominent medical school at the time, the Kanazawa Medical School, and he was essentially a clinical ophthalmologist as well as a professor for most of his career. But this is why it's called Takayasu arteritis. So you have all these eponyms floating around. One of the questions is, well, how to organize all this? And in a very important paper that came out in the Annals of Internal Medicine in 1978, tried to do this for the first time. They called it the spectrum of vasculitis. I should notice this came out of some people at NIH, and the lead moderator who wrote this paper was Anthony Fauci. Uh, this talked about vasculitis being a clinical pathologic process characterized by inflammation and necrosis of blood vessels. Quite straightforward, but with increases in pathology understanding and some of the treatments being used from a immunosuppressive standpoint, they felt the need to start to put all this together and described several of them as characterized distinct entities. So what were the entities that they described? Well, they started with a polyarteritis nodosa group of vasculitises, all of which seem to have necrotizing vasculitis. This included classical PAN and allergic granulomatosis. Also described a slightly separate hypersensitivity vasculitis and some subgroups of that where it seemed like the problem was more to be immune complex mediated. So you had serum sickness-like reactions. You had Henoch-Schönlein purpura, cryoglobulinemia with vasculitis. Then you also had separate entities like Wegener's granulomatosis, and then the other things like giant cell arteritis, temporal arteritis, and Takayasu's, since they both have giant cells or large multinucleated macrophage type structures in their pathology, and then a couple other conditions which were just kind of general. So that was the spectrum of vasculitis being described in 1978. Now, then you get into papers that start to pull us apart a bit more. And there are different terms for how they do this. So I want to go through very briefly. There are differences between papers describing nomenclature, classification criteria, and diagnostic criteria. So nomenclature referred specifically to names that would be used for specifically defined disease processes. Classification criteria specified what findings must be observed in a specific patient to classify that patient for clinical research is the key part here. There were observations that classified a specific patient into category for study. So as more and more clinical research was trying to be done on patients who had these relatively rare conditions, they all needed to agree that a given patient had a condition, so they had to meet classification criteria to get into studies. Related but slightly different are diagnostic criteria, which were observations that demonstrated or confidently predicted the presence of the defining features of the disease in a specific patient. Gets more at what we really need to do from a realistic standpoint clinically. So the American College of Rheumatology in 1990 developed classification criteria for a number of different conditions. I'm going to go through them very quickly. Polyarteritis nodosa was one of them. These were all published in the in Arthritis and Rheumatism. So there were 10 items here. I'm not going to list through all of them, but a number of them you recognize. One important factor, hepatitis B was getting recognized as a probable pathologic factor within polyarteritis nodosa's development. Libido, weight loss, testicular pain, myalgias and weakness, and then the role of biopsies. So if you look at these 10 items in 1990, for classification purposes, a patient shall be said to have PAN if they had at least 3 of these 10 criteria. For the criteria that were put out for Churg-Strauss syndrome, also in 1990, you had these 6 items: asthma, eosinophilia in the blood, neuropathy, pulmonary infiltrates, paranasal sinus abnormalities, and extravascular eosinophils seen on a pathology specimen. For classification purposes, a patient was said to have the condition if at least 4 of these 6 criteria were positive. For Wegener's granulomatosis, same 1990, you had these 4 items, and they were a patient was felt to be potentially classified as having Wegener's granulomatosis, still called that at that time, if they had 2 of these 4 criteria: nasal or oral inflammation, an abnormal chest radiograph showing nodules or fixed infiltrates or cavities, abnormal urinary sediment with microhematuria, or granulomatous inflammation on a biopsy. Giant cell arteritis criteria, 1990, once again, 5 items listed here. age over 50, new headache, templar artery abnormalities, either tenderness to palpation or decreased pulsation, elevated sed rate, the lab test as we expect, over 50, not necessarily has to be that high, and an abnormal biopsy. So for classification purposes, they had giant cell arteritis if they had at least 3 of these 5 criteria present. Henoch-Schönlein purpura. 1990, they needed to have at least 2 of these 4 criteria to be present to be classified as Henoch-Schönlein purpura. Purpura, age less than 20, so we know this is seen in the pediatric population largely. Bowel angina, diffuse abdominal pain worse after meals, suggesting bowel ischemia, and on biopsy, granulocytes seen on biopsy in arterioles or venules. Classification criteria for hypersensitivity vasculitis. Age greater than 16, needed to be on a medication that you could potentially say was a precipitating factor, palpable purpura, other maculopapular rash, and a biopsy which included arterial and venule showing granulocytes. Needed to have at least 3 of these 5 criteria to be present to meet these criteria. Takayasu arteritis, similarly, you had to have 3 out of these 6 criteria, age less than 40, claudication in the extremities, decreased brachial pulse, blood pressure differences between the arms, bruit over the subclavian artery, and arteriogram abnormality. So that was in 1990. So how do we get closer to where we are today? What changed things? And what really did change things was the fact that it became recognized that the ANCA, the anti-neutrophil cytoplasmic antibody, had a recognized role initially in Wegener's granulomatosis. This is a very important paper published in The Lancet in February 1985. Looked at patients who had Wegener's granulomatosis. It had been noticed that this antibody against extranuclear components of polymorphonuclear granulocytes or neutrophils was detected in 25 of 27 patients in the serum of patients who had active Wegener's. It was only seen in 4 of 32 samples in Wegener's patients who did not have active disease activity. So the ANCA was really a hot item to be studied in the late 1980s. So let's make a quick distinction. Immunofluorescent tests get kind of confusing for people who don't live in this space all the time. There are anti-nuclear antibodies that we do a lot of, and then there are anti-neutrophil cytoplasmic antibodies, a distinction of the substrate the test is being done on. For ANAs, the substrate are HEP2 cells, which are human larynx epithelioma cancer cells, okay? You are looking at the nucleus of this kind of generic strain of cancer cells that are used in many, many tests. For anti-neutrophil cytoplasmic antibodies, the substrate is a neutrophil. It's not this HEP2 cell. And there are 2 patterns that might be seen, the C-ANCA and the P-ANCA. The C-ANCA is cytoplasmic staining, specifically, tends to correlate with antibodies to a protein called proteinase 3. The P-ANCA was perinuclear staining, so still not in the nucleus, it's around the nucleus, and it tended to correlate with antibodies against myeloperoxidase. So what's important? That was 1990. The paper from ACR, the papers were 1990. That 1985 paper started to describe ANCA. A lot of research gets done. In 1994, there's a large consensus conference on the nomenclature of systemic vasculitis. The goals of the conference to reach consensus on the names for some of the most common forms of non-infectious systemic vasculitis and to construct root definitions for the vasculitides that were so named. Interesting, famous participant in this conference, Jacob Churg, was still around. So what did this consensus come up with? Well, they essentially took, they cut it down by size of vessels, large, medium, and small, and there was an increasing reliance in the descriptions here on pathology, looking for whether necrotizing descriptions were present or not, whether granulomas were present or not, and whether immune complexes were present at all. And I'm not going to read through this, but you can see there are several different small vessel vasculitises, a couple medium vessel vasculitises, and the 2 large vessel vasculitises. And those factors are all in these descriptions. I'm not going to go through them in too much detail due to limited time. What's very interesting, this is 1994, there are 2 here which have these little double stars, where it was stated these were strongly associated with anti-neutrophil cytoplasmic antibodies. This is stated in 1994. They also talk about a new one called microscopic polyangiitis, which was actually a preferred term because this involved angiitis, not just arteries. So I'll skip to the next. 1994, then 1992, the Chapel Hill group gets together again. Why? Well, now there's much more information about the ANCA and really ANCA association. So they took that previous categorization, large, medium, and small, added a few more variable vessel vasculitides associated with probable etiologies like infections, Hep C, Hep B, but the most important part that was changed in 2012 was this ANCA association. And they split up the small vessel vasculitis category into ANCA associated, which included microscopic polyangiitis, now known as MPA, granulomatosis with polyangiitis, what was Wegener's, so we refer to that as GPA, and then in an effort to get a pathophysiologic descriptions, Churg-Strauss is now being called eosinophilic granulomatosis with polyangiitis. These are all ANCA associated. So then you have the non-ANCA associated, which they're called immune complex small vessel vasculitis, which includes cryoglobulinemic, IgA vasculitis, and so those are the immune complexes seen in Henoch-Schönlein. Another one that relates to hypocomplementemia and urticarial vasculitis, and then the final one, what used to be called Goodpasture syndrome, is now really known as anti-glomerular basement membrane ambine. There again, immune complexes at that level. So this was 2012. Very important differences. This is a nice schematic visually of the size of the vessels and how these categories come out. You'll see this diagram in lots of different textbooks and articles, but just another way to look at it and help keep this straight, or at least somewhat straight in your mind. So since those 2012 nomenclature have been put out, what has been updated? And what I would say is that in 2021, just June of this year, the American College of Rheumatology put out guidelines for the management, not the diagnosis, so we're not getting into the details of this, but be aware that these are out there. There are 6 different vasculitises that have specific management guidelines that are updated because of all the advances we've had in immune complexes. They have one paper about ANCA associated, so it covers all 3 of these in one paper, a separate paper on polyarteritis nodosa, and then a third paper from June that covers the 2 giant cell arteritis, temporal arteritis, and Takayasu arteritis. Now, the final topic we'll touch on is how to use this in approaching a patient, or what test should I order. So let me give you a quick scenario. You have a patient who comes in with fatigue, fever, arthralgia, myalgia, rash, slight cough. Clearly a sick person. Age at this point is not really relevant to what I want to get into. So the big question in your mind as a good internist is probably, are they infected, or do they have some sort of systemic inflammation? So the first test you're going to do, obviously, a CBC, a chemistry panel. You're going to do a urinalysis because you don't know what's going on, and a chest x-ray, especially with the cough. So what initial rheumatologic test would I do before I even know anything more? Well, I'm going to do a sed rate and a C-reactive protein to get a sense of, is there lots of inflammation going on? That's quite reasonable. I don't usually order an ANA or an ANCA right off the bat, but in this person with this constellation of symptoms, with rash, cough, fatigue, fever, they are sick. And the likelihood, the pretest likelihood in a way that they're going to have, maybe they have lupus, maybe they have some systemic vasculitis, is high enough, I'm not calculating it, that I would do these tests initially. I wouldn't do the various subtypes, but I would do the screening tests and ANA and ANCA. So then, based upon the results of those tests, what to order next. So these are tests that should not be ordered up front. They should be ordered after you have at least a little bit more lab information. What would those include? Well, the ANA, like all tests, is not perfect. So you might have an ANA screen that's negative, but in fact, they have a clinical picture quite consistent with one of the ANCA-associated vasculitises. And in that case, I would in fact do a specific test looking for anti-proteinase 3 or anti-myeloperoxidase. Similarly, if ANA was positive, I would do those tests to confirm and to get a sense of potentially how high those antibodies are, because sometimes they go up and down with activity. I would, if in fact there's evidence of vasculitis or lupus, I would do a complement level, a C3 and a C4. I would not do that until I knew that those two conditions were, or one of those conditions were positive. If the liver function tests were abnormal, or I knew they had one of these vasculitides, I would then do Hep B and Hep C serologies. I probably would do them pretty soon anyway, because I'm going to want to know that if in fact I'm giving someone some sort of immunosuppressive treatment soon down the line. If they have a vasculitis, you might do cryoglobulins, you might do glomerular basement membrane antibodies, but I would do those if I knew some of this information up front. I would not do all of these tests when the person is getting admitted through the emergency department. I see that done far too often, and then people get borderline tested. They don't know what they mean, and they probably should not have been done in the first place. So high clinical suspicion, yes, do those. You may do these very soon thereafter, but I would try to avoid doing these tests on the bottom row right out of the gate. At this point, I think we're hitting the 30 minutes, so I want to thank you for your attention. I think we might have time to do some live question and answer. I'm not certain. I want to leave you with one of my favorite quotes from Sir William Osler. I think studies around vasculitis clearly demonstrate that medicine is a science of uncertainty and an art of probability. Thank you very much for your attention. I hope you have a wonderful meeting.
Thank you very much, Dr. Robert McClellan, for your excellent presentation. And this was the last lecture for today, and this concludes today's program. And the tomorrow programs start at 7 o'clock. We will meet you again tomorrow morning. Thank you very much for your